Okay, well, thanks a lot. This session is on the intersection of hyaluronic acid injection. We're going to go over some cases, do some techniques, and look how this study and how the whole idea of HA really goes along with the pandemic and what makes it different now as opposed to before the pandemic. So, and I'm from Halifax. So this is my disclosure. So I received some research monies from a lot of these industries. So we're going to look at examining the clinical outcomes, looking at some case studies, reviewing the step-by-step procedure for HA injections, and explore the protocols for HA injections during either before the pandemic and after the pandemic, whether that's changed a bit. And as you'll see, I will point out how that's changed my technique a little bit. So how did I get into this whole study of HAs? I'm the president of the Canadian Orthopedic Trauma Society, and it's a promoter of multi-center research studies that are prospective and randomized for the last couple of decades. So I was approached by companies to do a study on HA. So initially we started with just a few surgeons, 2 or 3, and now in 2018 we have 60 surgeons and 20 research coordinators. You can see that it was between 2001 and the present day, so it's really grown, and as has our protocols. So you can look at some of the publications that we've done in the past that really changed the way orthopedics is practiced today. That we did prospective randomized trials looking at calcium phosphate and tibia plateau fractures, and we also were the promoter of plating midshaft clavicular fractures. So that's totally different than what we did prior to these studies. So in the same way, we hope to have the same effect when you look at non-animal animal stabilized hyaluronic acid injections and moderate osteoarthritis of the knee. And as you'll see in the pandemic situation, you can actually put that forward to more type 3 and type 4 osteoarthritis of the knee as a temporary relief for the patient. So again, why do we need injections? Well, really, non-steroidal anti-inflammatories have been really the stable plate of what we do with these patients. So here's a look at a patient, 68 years of age, who has osteoarthritis of both of her knees, and taking non-steroidal anti-inflammatories for the past 8 months. But when she comes in to see us, she complains that her pain's been getting worse. It really hasn't been taking the medications, hasn't been doing the physiotherapy, and she's thinking of stopping all of her treatments. So why would that be? And so here are some further x-rays showing that she's got some osteoarthritis. When you look at her again, despite physio, bracing, and non-steroidal, and she comes back having done all these 3 things, she's still getting worse. So what do you do next? She really doesn't want to have surgery yet. So she's 68 and wants to put off surgery if she can. So what are our adjunctive therapies that we can offer? We're looking at steroid injections, either depomedrol or triamcinolone. Hyaluronic acid has been excellent, sort of grade 2 and grade 3 OA, but no real good studies to show that before this one. And then glucosamine and chondroitin sulfate really seem to be pretty good for the first 3 or 4 years, but at 5 years haven't really shown good promise. So they had some effect and then sort of deteriorated over time. And you look at PRPs and stem cells, again, no real level 1 evidence to support those at this stage. So despite being good treatment, non-steroidals are very good, but they have some troubles with GI problems and cardiovascular risk factors. And so at this point in time, if you choose to use those, if the primary concern is GI risk factors and COX-2 inhibitors and a PPI is recommended, if the primary concern cardiovascular or blood pressure problems, then naproxen and PPI is probably the preferred combination at this present time. What are the alternatives? The problems is that despite these treatments, 30 to 40% of patients really can't stand non-steroidals over the long term, and they get dyspepsia, peptic ulceration, and hemorrhage and small large bowel bleeding. So that leads us again to what else do we have to offer these patients? So this is what really led us to a randomized blinded trial comparing single stabilized HA injection to corticosteroid for osteoarthritis for pain. So we had 15 investigation sites in Canada and 4 in the United Kingdom and 5 in Sweden. So one or more of the authors, of course, we received research and other financial support, but no in-pocket money. The Durline Study Group went over a long stretch of territory, and this is important because you can really take the results from this to be attributable to your patient population. If you have a study that's really done in only one local area, you always worry that maybe that may not be attributable to your population. But this wide, broad area of sites would indicate it would be attributable to most populations. So the 2 type of things we looked at were HA viscosupplementation as part of the OA treatment And basically, it's an entangled network of HA chains and a covalent bond. And how did that differ from ones beforehand? Well, really, the ones beforehand were really animal-based, involved peptide bonds, and they really deteriorate a bit more quickly. They also caused some troubles with immunogenic response. So some of them became problematic to the patient and caused synovitis. So just to step back, how does that change now the pandemic is upon us? Well, the treatment plans are pretty similar, but it makes these studies even more valuable as we're trying to treat patients and maintain their pain as they await surgery, because right now they can't get in to get surgery done as rapidly as they could before. So we've modified this now to suit the situation by adding a bit of methylprednisolone to the patient initially. So initially, if we did the studies, you'll see we wanted to have knees that did not have synovitis or fairly dry, and we could add the HA to the knee joint. Now you have a patient who presents in a pandemic situation with a very swollen knee and full of synovial fluid. Now with this sort of treatment plan we do now with the pandemic, we will actually put a 18 gauge needle in the patient's knee, drain the knee of all the synovial fluid, add 2 cc's of methylprednisolone along with the HA treatment. And so you get the synovitis treated by the methylprednisolone, at the same time get the long-term gains of HA, which have proven to be very equal to what we saw in this study. The injection of the knee joint can be done superior and lateral, as you'll see. Most of them were done that way, but also straight medial, which is my favorite. But I think these are the two most common injection sites of the knee joint. But many portals exist, and many very excellent injectors can use all sorts of portals to the knee joint. Once you get in the knee joint, you're sure about it. The main thing is to inject the knee, really feel the knee, feel the thrill of the injection going in the knee joint, and make sure that your patient is relatively pain-free after they receive the bupivacaine or xylocaine, whatever you choose to use. How does HA work? Well, it's mechanical. The entangled strands bonded with covalent bonds as opposed to peptide bonds have proven less immunogenic, as I pointed out, and appear to have a longer duration of action within the knee joint. Homeostatic, the HA of any type enhances the body's normal synovial fluid. So instead of having arthritic synovial fluid in the joint, you get a more normal synovial fluid, which enables the synovial lining cells to produce normal or more normal fluid. So we think this is good. We also find that as we move forward in our HA production, that HAs with higher molecular weight appear to work more efficiently than those with lower molecular weight. So we'll point that out at the end as to what to use. So our working plan was that we know that methylprednisolone or steroid works in the knee joint. An intra-articular injection is a standard of care that has demonstrated a therapeutic profile in studies beyond 12 weeks. So we thought if we use that as a standard of care, before this study, everyone used saline or some other non-working treatment. So this was the first study that really showed that HA can work as well as or better than methylprednisolone. Study design was mild to moderate knee osteoarthritis, did prospective, randomized, double-blind, active control study, and did a non-inferiority study, which actually proved out very well. So 6-month blinded phase and a 6-month open label extension phase. The reason we did this is we wanted to reward the patients with a free injection to see what they did, number one, to make sure they received something from the study, but also, number two, if they received 2 injections within 6 to 12 months, would they respond with an immunogenic response? And as you'll see, they did not. We also worked out the power analysis because there are lots of examples of randomized protocols that we've done with the COTS group. We knew that the power to prove this would be about 400 patients. And that's important because when you look in the studies, the literature, most studies have 100 to 150 patients. This is one of the few studies that has 442 patients that actually allows you the power to make some of these statements that we can make in our study. Follow-up visits for the routine orthopedic visits, 6, 12, 18, and 26 weeks. Then the open label phase, we just looked at the 9 and 12 months. We wanted really to look to see whether they got a second peak of improvement from the second injection, whether they received any immunogenic response from it, which they did not, as you can see. So primary endpoint was a WOMAC pain responder rate at 12 weeks, an improvement of baseline of 40%. The secondary endpoint was really the composite of pain and function of the patient or global assessment. The WOMAC is a widely used proprietary set of standardized questionnaires really to look at measures for pain, and it measures 5 items for pain, 2 for stiffness, and for functional limitation. So basically a higher score for WOMAC indicates worse pain. The inclusion criteria is 35 to 80 years of age, unilateral knee pain, meeting the ACR criteria for diagnosis of osteoarthritis, Kelvin-Lawrence radiographic score of 2 or 3, WOMAC pain score of 7 to 17, noting the high score is the worst pain, and body mass index of less than 40. We chose 40 just because we felt there had to be some cutoff where we would be unsure whether our needle would enter the knee joint or not. We thought 40 was probably it for most people. After that, we thought that you meant to use a radiographic sign of entering the knee joint like an X-ray or ultrasound. Exclusion criteria was a clinically detectable knee effusion. And the reason is that we wanted to make sure that we got the pure effect of the HA. It doesn't mean in a clinical study you have to wait till the knee's very dry. As I pointed out, you can drain the knee, put in a bit of steroid and add the HA. But in this study, we wanted to make sure there's no parameters where you could second guess and say maybe they didn't get the full effect. Clinically significant contralateral knee pain. Again, we've done some studies before that showed if you had 2 or more joints involved that a second knee could deteriorate your WOMAC and not allow you a good score. We want to make sure, again, just to be pure, that this study involved 1 knee joint only. Can you inject a patient with 2 knee joint problems? Sure you can, no problem. So clinically you can do it with 2, but in the study we just did 1. And clinically significant joint pain for joints other than the study knee, again, we felt that if you had a horrible shoulder or horrible hip, that would give you a WOMAC score that would not be indicative of what your knee had done. So again, just for the study, we rule that out. So again, not that you couldn't do that with patients that you were treating, but that we did it just for the study. Patient demographics and baseline data balance between the 2 groups. Again, it's randomized. You'd expect to do that. High percentage of completers. We really did the power analysis to allow for 80% completion. You can see we have 96% completed at week 26, which is pretty good. So Durolane and MPA were both active at 12 weeks, which we would expect, but the Durolane effectiveness sustained and MPA effectiveness decreased. So here's the study, the slide you want to take home to, if you're going to use HA, you can show it to your patients to say, you know, at 18 weeks or so, there's going to be a crossover and your steroid is going to gradually decrease and your HA injection is going to keep on going to 6 to 9 months and maybe to a year. So that's really the study that you want to keep in your mind and the graph you want to keep in your mind. Secondary outcomes, again, at week 26, the change from baseline to WOMAC score was statistically significantly larger for Durolane compared to steroids. So much improved increase, so about a 65 or 70% improvement. Again, there was no device-related serious adverse effects. So we're really looking for any type of immunogenic response, synovitis, and nothing really happened. There were some arthralgias, minor aching of the joints and periarticular muscles, most common minor aggravation. You can see here that arthralgia is 38 or 17% in Durolane versus 7 of the MPA. We felt this was due to the fact that most patients expected an improvement right away, and the Durolane or HA, whatever HA you use, it'll probably take about 5 to 7 days to come on stream. So you should suggest that to your patients, that use just HA alone, it's going to be a week or so before they get their effect. We also asked all of our patients to take it very easy for the first 48 hours. So if you're going to use any type of injection in the knee joint to control synovitis, you want to make sure they take it easy, ice the knee down for 48 hours after they get the injection. So don't go play golf right away, but try and take it easy. Don't shop, don't play a sport. So repeat Durolane injections improve. So one of our questions when we repeat the injection was, do they get an improvement? And also one question I asked was, well, if the patients receive steroid first, would they actually notice an improvement with just the HA injection? Indeed, you can see both of them showed some improvement, very similar arcs after they get the second injection. So even though they had steroid first, they still showed marked improvement after the HA injection. So potential criticisms of the study, measurements are subjective, could be related to patient effect. That's most likely during the second injection. So when you get something that you know you received an HA, most patients want to do better. So they could say, well, I got better just because I got the injection. I want to be compliant with the study. But in the first one, they were totally blinded. And so you would have to say that that would be not probably patient effect. The other thing is we only investigated Kelvin-Lawrence in 2 and 3. So as we're finding in the pandemic, we're sort of choosing to inject some of the higher grade injections, such as the grade 4 osteoarthritis. And if you do those, again, I would probably suggest that there's a probably 50 to 60% chance you're going to improve, but there's a 40 or 50% chance they may not get a sustained effect from this. Sustained effect in a grade 4 would be probably 3 or 4 months. So what we wanted in this study is to be 6 months or greater. So the strengths of the study are it's a level 1 evidence. Only 10% of whatever you read in the orthopedic literature is really level 1 data. It's randomized, multi-center, prospective study. The control group is an acceptable, active standard of care, so we know it worked. Separate and physicians injected the patient, so it was double-blinded. It was excellent follow-up, as we saw with 96% follow-up and compliance. So I'm going to go into some studies that will illustrate what we did with these patients and also show kind of what we're doing with the pandemic patients as well. So here's a 34-year-old female presents with painful knees, right greater than left. At 34, she doesn't want a total knee replacement. So lateral greater than medial, and this side she's had bilateral, lateral meniscectomies done when she was a teenager, and pain despite excellent conservative treatment. So unloader brace, non-steroidal anti-inflammatories, and physiotherapy. So you can see here we did the leg lengths in alignment. The right was greater than the left as far as pains go. And you can see the lateral film showing that her posterior compartment looks pretty good for flexion. So in those days, we did a posterior varus distal femoral osteotomy. So we flipped it over. So we put the weight from the lateral side to the medial side, and we thought we obtained very good pain relief. So post-plate removal, pain was good, 2 out of 10, so she was happy. The other side was doing reasonably well, and she was quite comfortable for a few years. So we took the plate out, and then she came back about 3 years later with pain in both knees. So the osteotomy that I did was no better than the other side. You can see the joint spaces are a bit better in the osteotomized knee, but still no better in pain. So we didn't want to go through another osteotomy at the age of 37, so we suggested to her maybe injections of HA. So we did single joint injection. HA began in 2008 and yearly since then. And the pain, every year she'd come in and get the injection, and the pain went down to 2 out of 10 or less. She had one time where she came in and everything was going so well that she went out and played golf the next day, and she came back and about 2 weeks later said this injection didn't work. And when we examined it, we found out that she hadn't really spent some time letting the injection do its thing. So I think it's really important to really make them take some time off after whatever injection you do to allow the injection some time to have its effect on the synovium. Other injections worked. Eventually, however, still look reasonable. Pain about the same at 42 years of age. And then in 2014, the injections had a reduced effect on the right knee. That's the knee I operated on. The left knee was still doing pretty well with the injections. So we went ahead and did a total knee replacement on the right side. I was hoping to get to 50, but we didn't quite make it. And she received a right total knee, but still receiving single injections, HA once per year in the left knee, and it's still functioning well. So I think that it's sustained itself better than the osteotomized knee at that point. So still a long time for injections once a year, except for that one failure that we had. Case 2, again, it's an interesting patient, totally different patient. So 50 years of age, very active, hockey, golf, etc. Tore his meniscus in the right knee. So I scoped it, removed the meniscus, thought I did a pretty good job, but he was worse after the scope. And many patients do this. So they're 50 years old, you scope them, you take the meniscus out, they actually get worse for a while. So clinically painful medial aspect of the knee, nothing new. I thought maybe I hadn't removed all the meniscus because he was so uncomfortable. Did repeat the MRI, nothing new except for showed the scarring where the meniscus had been taken out. So non-steroidal anti-inflammatories, we gave him strengthening, medial offloader brace. Still at 2 months, he wasn't very happy with me, despite being a good friend of mine. So I said, well, we should try this injection of HA. And so we did a single injection of HA with marked improvement over about 4 weeks. Received this twice a year for about 5 years, and then going very well, and we decided to stop doing the injections. He's still going strong. He still uses the brace for sports, for hockey and for golf, but doesn't use the brace in between. Going strong. He's needed no 2 injections for 3 years now and is doing very well. So again, it's a very nice thing to use after a scope in the older patient. So case 3, again, a different age group, 75 years of age with pain involving both knees, received steroid injections and was better, but they weren't sustained. So she would get it, and then 3 or 4 months down the road would want another injection. So again, stable knee to examination. That's an important aspect, because if they're unstable, again, an offloader brace may be considered. If they're stable, however, a light brace may still be added, but not going to be a big benefit to her. So not any anti-inflammatories, because she didn't feel she wanted to stress her kidneys with her anti-inflammatories at 75 years of age. So we started injections. She's now 80. She's had injections yearly. Still bilateral knee pain, but not bad. She doesn't require surgery. She's on a treatment plan with physiotherapy. She wears light braces occasionally, injections of HA plus symptomatic treatment with Tylenol. So again, 5 years have gone by. She's doing very well and has had no surgery. So that's fantastic. The things that you can take away for pandemic type patients. So case 4, MB is a 58-year-old male with osteoarthritis, experiencing pain despite excellent medical management. So Depomedrol injection worked reasonably well, but only lasted about 6 to 8 weeks maximum. So we started doing 3 ml injections every 9 to 12 months in both knees, and he's done very well. Now he had an episode where I injected him, and he didn't get a lot of relief from it early on, but then got late relief. So we thought we'd add 1 ml of methylprednisolone. So we did it that time, and since his first injection, he received 1 ml of methylprednisolone along with his HA, and he's done very well. He gets the early improvement from the methylprednisolone and the late improvement from the HA. So we've gone on to use that knowledge now with our pandemic patients who come in with a swollen knee, awaiting surgery, and so we can drain their knee, put the steroid involved, and then add the HA to it for more sustained relief. And that's worked very well. Case 5 is a 43-year-old male with osteoarthritis of his knees and an HTO, again, a medial opening wedge osteotomy on the right with good results for 8 years, and then came back with pain involving both of the knees. So increasing pain 8 out of 10 on the right knee, 6 out of 10 on the left. Both knees prompted a trial of HA injections. We have done this routinely now. So 6 years later, really no change, improved symptoms 2 out of 10 at most. He plays hockey, does some sports with his children, and radiologic findings. Really interestingly, if you look back at this, they haven't really changed very much. So here he is, 8 out of 10 and 6 out of 10 with pain. And then 6 years later, the joint spaces haven't changed too much in 6 years. And so I think that's really done well. So looking at HA following arthroscopy, to be very clear, we haven't done any randomized trials in this aspect or this particular use for single injection, despite that case I showed you. But based on our studies, we've made some careful observations. So injection should be done in a quiet knee. So I don't think you should do it around the operative time, but certainly a week or 2 down the road would be the right time to inject HA if you feel it's necessary. Like I did with my patient, probably too late, but I think he got the result from that. So knees with noted grade 2 and grade 3 at the time of scope, OA in one compartment are going to be excellent candidates for this type of treatment, similar to the case that I showed you. So you would expect improvement in the patient, and you expect him to get later improvement if you had to do it down the road. So repeat injection, if required, would be expected to be successful and well tolerated. We also looked at some studies looking at medical economic evaluation of HA to see whether this makes sense from an economic standpoint. So the cost of osteoarthritis decreased during the 6 months after HA injections, indicating the cost of medication was more than offset by the decreased need for treatments. And this is important, again, in the pandemic patients. So they're taking pills and paying for them, going through, they're wondering whether the cost of this injection is really worth it for them. But if you can decrease their need for other medications, and not only that, if you can keep everything the same but have their activity improve, even that's worth it for them. So two signs of pain relief are, number 1, the same pain with improved activity, or number 2, the same activity with improved pain. So you have to look at that with your patient, see which one they have. But this really shows that under the conditions of everyday practice, HA may provide medical benefits at an acceptable cost. So I think in conclusion, HA in a single injection, in my opinion, has shown excellent efficacy in the population studied. Studies suggest that a single injection of this product continue to be effective out to about 26 weeks and can be as long as 9 months or a year, as you can see from some of my case studies. So in this study, repeat injection did not create any short-term synovitis or long-term immunogenic response. In this study, repeat injections improved the responder rate in these groups, so repeat injections can be done with great confidence. No significant safety signals appeared in either phase aside from arthralgia. And again, if you have a patient that develops that in their first injection, as my patient did, then I think adding a cc of methylprednisolone along with your HA is a very good way to prevent that in future injections. So I think the device can be used safely with predictable positive response in Cogan-Lawrence 2 and 3 patients. Unfortunately, I don't think you can say the same as Cogan-Lawrence 4, but I think in today's world with the pandemic, we try that with the patient, provided they've been assessed and they know that there's a 50 or 60% chance of improvement, but also a 40 or 50% chance that it won't help them. But I think if they understand that and go for that treatment, it's a reasonable thing to do, recognizing that we would accept a 3 or 4 month improvement rate in those style patients versus what we really want. And a Calgon 2 or 3 patients, if they don't get 4 to 6 months, I wouldn't suggest a reinjection. So they really should get a predictable 4 to 6 months, whereas the ones you're doing in the pandemic that you're just trying to help them until they get their total knee, I think you could accept a much lower time period of improvement. So the treatment regime is even more relevant for our patients in the time where our resources are just not there for them to do the operative procedure in the pandemic. So this has been published with Osteoarthritis and Cartilage, as it's a widely read article with an impact factor of 4.62 and can be read by anybody, not just orthopedic surgeons or sports medicine physicians. So I think it's the right place to read it if you want some more details. I just want to spend some time on the details of doing a knee injection, because it's done in variable ways by variable people, but I think the things that are consistent with every injector are to get everything ready before you get going. So our routine now is to prep the needle with the chlorhexidine and alcohol prep. Certainly alcohol seems to be the most consistent about everybody who uses it. So, but we use chlorhexidine and alcohol. We use a sterile tray, but we just use gloves. We don't tend to make everything particularly sterile but clean. So I think the idea is to get everything ready ahead of time. What I do is I get 1 or 2 cc's of methylprednisolone along with bupivacaine. That's what I use for injections. So a 0.55% bupivacaine with epinephrine. And the reason you use epinephrine is it just lasts a bit longer, prevents some bleeding. So what I do is I gotta draw that all up with a non-sharp needle, so a blunt needle, an 18 gauge, put that all in your syringes, and then have your HA delivery system ready to go after that. Once you prep out the knee, depending what portal you use, I use a straight needle, but an anterolateral is fine. Get the patient laying down with their knee on the same side that you're on, and then make sure that you can palpate and feel where the knee is going to behave. Then you take a 22 gauge needle. This is important to note. An 18 gauge needle you can use to inject the skin if you want to ahead of time. I don't do that, but that's reasonable. So a little xylocaine with an 18 gauge needle and a small needle to prep the site you're going to inject to avoid a bit of pull back by the patient's reasonable. So if you're less confident about getting the needle into the joint right away, then certainly xylocaine with an 18 gauge needle it makes perfect sense. If you're going to go right to the injection, you should use a 22 gauge needle or larger. And the reason is that depomedrol and methylprednisolone are fairly thick and they don't go through a 25 gauge needle. So you're not going to make the patient any happier by using a 25 gauge needle. If you want to use it for the skin, that's fine, but to inject the knee joint, should use at least a 22 gauge needle or bigger. If you're going to inject HA, which is a fairly thick type viscous fluid, again, 22 is the minimum you want to use. So 22, 20, or even an 18 gauge needle could be used. I don't think an 18 is necessary, but it goes through there very easily. Now, if you're going to drain a knee, again, that's step aside one more time, then an 18 gauge needle is the ultimate. So if you're going to drain a knee, I put a 25 needle, freeze the site, put an 18 gauge needle in the knee joint, use a 60 cc syringe to take the fluid out as much as you can, take it down to as low as you can get it and get that right down. Then take that syringe off, leave the needle in the knee joint, and then attach your bupivacaine and methylprednisolone if you're going to inject that, or bupivacaine alone. And then once that's injected and you really know you're in the knee joint, you're happy that you're getting fluid both ways, then put your HA into the knee joint. If you're going to inject the knee without an effusion present, so then you put the 22 gauge needle in and you inject the bupivacaine or methylprednisolone and bupivacaine mixture and make sure it flows very freely. As long as that's flowing freely in the knee joint, you feel a thrill in the knee joint as you fire the fluid in, and you then detach the needle, add your HA, and then inject that in the knee joint. So one needle stick should accomplish all of that into the patient. The important thing after you finish is to put some pressure on the position of entry, make sure it's dry before you put a Band-Aid on it, and then you're not done yet, okay? You have to wait about 4 or 5 minutes, make sure that the patient has achieved good freezing of that knee joint with the bupivacaine or xylocaine, and then examine the knee joint. They should be relatively pain-free at this time. If you've injected the knee joint, they should be comfortable. If they have discomfort and they haven't received any benefit from bupivacaine or xylocaine, the likely thing is that you're not in the knee joint. It's not a shame to tell them that. And I would say, look, I don't think that where I want it to go, I want to re-inject again or put some more material into your knee joint. So some people even say you should do that first and examine. I don't think you have to go that far, but the examination of the knee joint after the injection is part of the injection procedure. Okay, so you need a 10 cc syringe for the injection of bupivacaine with or without methylprednisolone. You need a 60 cc syringe for withdrawal of any synovial fluid that you need. You need an 18 gauge needle blunt to withdraw your fluids that you're going to inject, and a 22 gauge needle to inject the material. Or if you're going to withdraw synovial fluid, you need 18 gauge needle. So all that has to be necessary and ready to go before you start to inject the patient. If you have that already, it will go smoothly and clearly, and you'll be successful 95% of the time. So I'll take any further questions, but that's usually a question, and I think that answers most of the material. But the portal, again, is up to yourself, and you can read over where to inject, but it's important to make sure that your needle inserts underneath the patella and gets a good injection to the synovial area of the knee joint. I'd like to thank you for this opportunity to present this topic to you, and I certainly would accept any questions that you'd like to produce at this time. Thank you very much.
Okay, so hopefully you guys can hear me at this point in time. Welcome to the session. I'm Dr. Ross Layton from Halifax, and first question was, is there enough evidence to tell patients that HA halts the progression of OA? And indeed, there is not enough evidence at this point in time that hyaluronic acid would halt the progression of OA. It will help reduce the symptoms. There's been some evidence to suggest that if you do it in grade 2 and grade 3 Calvin-Lawrence arthritis, that it will reduce the symptoms and may prolong the effect of non-operative treatment. So you can put off a total knee replacement longer. But if someone's headed toward a total knee replacement, there's no evidence that it will prevent that from happening going forward. Now, next question is, why would some HAs last longer, perform better than others? And the reason is really that HA has changed a lot over the years, and that the weight of it, molecular weight, has become a bit greater. And the change from animal-based to non-animal-based has really changed things. So instead of a peptide bond, it's now a covalent bond. And those things have all elongated the length of time that the HA would last into a knee joint or hip joint. So if you inject the newer type HAs, they will tend to last longer than the older type HAs. So if you look at head-to-head studies looking at the earlier avian-based HAs versus the non-animal-based HAs, they last about twice as long in the joint and have better symptomatic recovery over the next 6 months versus about 3 months or so with the avian-based. So quite a bit of difference as time has gone on. So if you can get one with a better molecular weight structure and with a better covalent bond versus a peptide bond, that's where I would head with my selection of HAs at this point. As far as lidocaine administration, it's not really contraindicated. It's just the amount. So the whole thing is that if you put in too much and you dump in a lot of lidocaine or bupivacaine, then it would perhaps crystallize some of the HAs, but it has to be a lot of it. So as long as you stick to 2 or 3 cc's, I've been successful with both of them. I like bupivacaine because it allows the patient to get home for 4 or 5 hours before they get pain. So I think it works better for me and for the patient as far as getting home. But I think either can be used, but it's a matter of volume. So I think you stick with 2 or 3 cc's or 4 cc's of the freezing material, whether it be lidocaine or bupivacaine. I've been successful with both, but I use bupivacaine for my own patients because of the length of time it lasts for the patients and they get home without too much difficulty. How much time is recommended between HA injections and joint replacement? Same thing, really. This has been looked at many different ways, but 3 months is the safest, but 30 days would be the shortest time. So as long as you have 30 days, there's been no big studies that show a major difference, but 90 days is what you'd like to be. As a surgeon, I'd like to have no injections around the joint for 3 months before you do the surgery, if at all possible. But I have done some as early as 30 days, and some patients that just deteriorate or get called in early, and I've had no major sequelae. But the literature would support 30 to 90 days, but very soft studies that would indicate that. The statement about using steroid with concomitantly with HA, what that does is that if you have a patient that comes in with a large effusion or moderate effusion in the joint and you want to inject them today, if you drain the knee of any fluid and then you put a cc or so of steroid, 40 milligrams per mil, then that allows you to get rid of the synovitis, and then you can inject your HA with the same injection. In our study, we were very careful to stay away from those with joint effusions, and so we actually made sure that the effusions were all gone before we did the study. So that when you look at the study, it really shows the effects of hyaluronic acid in a knee that does not have a significant effusion. However, in clinical practice, it's certainly quite reasonable for me to see a patient with a mild to moderate effusion, put an 18-gauge needle in the knee joint, drain it of any fluid, put a cc of steroid in the knee joint, and then add the hyaluronic acid at the same injection. And they've had equal outcomes to my study patients, so I'm not worried about that. You can inject that day, and it's very safe to do so. Can you use HA in a Calgan-Lawrence type 4 knee? Again, you can, and that's been more indicated in these COVID type environments where people have to wait a long period of time to get their total knee. So you can, but it's about 50-50, and I warn them very clearly that they're not going to get, it's a 50-50 where they get a result from it. If they do get a result, you'd be happy with 2 or 3 months. So you're not going to get 4 to 6 months out of that. So if they're happy to try and get some relief for 3 months or so, then that's good. I've had some that have done really, really well, much better than that, but I've had lots of failures as well that you inject it, it has no effect. So I think if you're going to use it in a Calgan-Lawrence type 4, you have to really warn the patients that it's a 50-50 split as to whether they get some effect. And if they do, it's likely to be more like 3 or 4 months versus 6 to 9 months. Okay, thank you very much for the session, and I appreciate your attention. Thank you.